Hello everyone, my name is Pingtong Fan from the Second Affiliate Hospital of Zhejiang University School of Medicine, Hangzhou, China. Firstly, I would like to thank Professor Hans Peter and Professor Doug for inviting me to have presentation here. My topic is contrast inhalation sound in gastric cancer. As we know, gastric cancer is still the fourth most common cancer and the second leading cause of cancer-related deaths worldwide. From this map, we can find the East Asia, including China, here is a high incidence area of gastric cancer in the world. Current treatment options for gastric cancer vary from endoscopic mucosal resection to preoperative chemoradiotherapy, followed by gastrectomy, and the preoperative diagnosis and classification, including the gross appearance and the T-staging, is critical in determining the optimal treatment of the gastric cancer. The use of transabdominal ultrasound for the gastric cancer is limited by the interference from the intragastric gas. Recently, oral contrast enhanced ultrasound can improve the images by displaying the gas in the stomach and by distending the gas lumen, thus can helping to display the mucosal layers. So we can find here this is a body of gastric and this is atrium and the duodenal bulb can be displayed clearly based on these methods. And now let's look at here. This is duodenal bulb, and also the layers can be displayed, and the lymph node also can be detected using these methods. And however, we can find the lumen of gastric can be planted with isoacogenicity with uh, well acoustic windows. And here I'd like to introduce a new method named double CUS DCEUS in gastric cancer, in which intravenous bubbles are used together with an oral contrast agent. And this is oral contrast agent. As for the oral contrast agent is composed by a kind of third derivative. It can reconstituted by adding 500 ml of boiling water and gently stirring the water to form a homogeneous suspension. After cooling to a comfortable temperature, the patient was asked to drink the palatable liquid as quickly as possible, and this can provide an acoustic window and enable transabdominal ultrasound to detect gastric lesions. And each part of the stomach and the duodenal bulb were examined in turn, with the subject in both supine and decubitus position to facilitate complete filling and the visualization of the ledger as clearly as possible. And when the ledger was displayed clearly here, and the intravenous CUS was performed after the administration of the 2.4 milliliter of the Sonavir as bolus injection, and so we can find the ledger were enhanced with a hyper enhancement in the early arterial phase, and this is a normal gastric wall, and this is a lumen of gastric, have no enhanced. And right now, I'd like to show the role of COS in assessing gastric cancer. First, to assess the gross appearance of gastric cancers preoperatively. And based on the Bowman classification, the advanced gastric cancers can be classified into four types. Type 1 is a nodular polypoid tumors without ulceration and usually with a broad base. And the type 2 tumor is an ulcerative lesions, but elevated and distinct borders. And type 3, an ulcerating tumor with penetrating, infiltrating base, and type 4, a diffuse thickening of the gastric wall without a discretive marginated mass or ulceration. So now let's look at some case, and we can find that the lesion present with polypoid nodular tumor with a broad base on B mode, and this is lumen of gastric with isoechogenicity, and also the lesion were planned with a hyperenhancement in the early artery phase. However, the lumen of gastric have no enhanced, and the lesion were located here on CT scan, and which can be classified into type 1 of the Bowman classification. And now let's look at this movie, and we can find the lesion were enhanced in the early artery phase with a hyperenhancement and homogenesis enhancement. However, the lumen of gastric have no enhanced. The another case, on B mode, the lesion planned with hypoechogenicity and were rapid washing enhancement with hyperenhancement in the early artery phase and the late phase, and the CT scan displayed the lesion's location over here. And this is a Bowman classification type 2. The lesion is an ulcerating lesion, but elevated and distinct borders on B mode, and on this US, and the CT scan displayed the lesion's shape over here. And here we can find the gastric wall thickened with ulceration and hyperechogenicity, and the lesions were enhanced with a hyperenhancement in the early artery phase, and the samples were harvested out the surgeon also can display the shape of this ulceration. And here I'd like to show the Bowman's classification type 3, and this lesion is an ulcerating tumor with a penetrating infiltrating base on B mode, and double contrast enhanced ultrasound and the CT scan also can display the shape of these lesions. And another case, we can find the lesion is not clear on B mode. However, after CUS, the shape of these lesions were clearly displayed in the early arch phase and the later phase. So this is an ulcerating tumor with a penetrating over here, infiltrating base, so which can be classified into type 3. And for this case, we can find that the gastric wall was thickened with a diffuse thickening of the gastric wall without a discretive marginated mass or ulceration on B mode, and double contrast enhanced ultrasound and the CT scans, which can be classified into type 4. And here, the another case, the gastric wall was thickened. So oral contrast ultrasound shows the thickened gastric wall or gastric atriums with a smooth and intact visceral peritoneum, and however, the ledges and the involvement of the visceral peritoneum is shown by double contrast enhanced ultrasound with a hyper enhancement and layered enhancement in the early artery phase. And finally, the histological findings showed that the signaling cells in the selosa over here. So this is a diagram shows that the visceral peritoneum is smooth and intact on the oral contrast ultrasound, while the involvement of the visceral peritoneum with irregular enhancement exists on double contrast enhanced ultrasound over here. So totally, the overall accuracy of double contrast enhanced ultrasound in determining the Bowman classification of advanced gastric cancer was 91.49%. The accuracy of DCUS in determining Bowman classification 1, 2, 3, 4 was the 86.96 and essential, respectively. The second part, I'd like to show the role of the CUS in assessing gastric cancer to assess the relationship between enhanced pattern of the CUS and the definition of AGC. And right now, the contrast enhancement patterns of AGC can be classified into two patterns. One is a homogeneous enhancement patterns, and another is a heterogeneous enhancement patterns. And now let's look at this case. And the ledges were enhanced with homogeneous enhancement patterns in the early artery phase without defect in the ledges, which can be classified into homogeneous enhancement pattern. And in that case, we can find the gastric wall thickened with a hypoechogenicity, and the ledges were enhanced with a homogeneous enhancement patterns in the early artery phase. And tubular adenocarcinoma with a well definition was approved by histopathology examinations. And here, the gastric wall thickened over here with hypoechogenicity, and this is lumen of gastric, and the CT scan displayed the ledger's location and shape over here. However, the enhancement began at the selosa and progressed to the mucosa with striated patterns. This is a selosa layer, this is a mucosa layer, and this can be classified into heterogeneous enhancement pattern. And here, I'd like to show another case. The gastric wall was thickened. This is a diffuse thickening of the gastric wall without a descriptive marginated mass or isolation can be seen on the oral contrast ultrasound, and also we can find the gastric lumen is a stenosis over here, and the enhancement pattern can be displayed on this video, and the enhancement began at the selosa and progressed to the mucosa with striated pattern, and finally the signaling cells can be approved by the pathology examinations of this case. And based on these tables, we can find the gastric cancers or the enhancement pattern can be classified into heterogenesis and homogenesis. And the gastric cancer with a heterogeneous enhancement were the more common pattern in the undifferentiated gastric cancers. And the sensitivity and the specificity of the double contrast enhanced ultrasound in diagnosing undifferentiated gastric cancer was 78.84% and 72.69% respectively. And also, gastric cancers with a heterogeneous enhancement were more often Bowman type 3 and type 4 and types than those with a homogeneous enhancement and were less likely to receive curative gastrectomy than those with a homogeneous enhancement. And the next part is the role of CUS in assessing gastric cancer to assess the effect of neoadjuvant chemotherapy in patients with gastric cancers. Now I'd like to show some case to you. And in this case, we can find before the therapy, the lesions can be displayed on B mode with a hypoglycemia. The size can be measured on B mode and can be displayed on the CT scan. And 2 months after the neoadjuvant chemotherapy, the lesion will disappear on B mode and the CT scans. And we also can use the double contrast ultrasound to assess the enhancement of these lesions. We can find this is a baseline stage. The lesion were enhanced with a hyper enhancement before the neoadjuvant chemotherapy, and 2 months after the neoadjuvant chemotherapy, the lesion have no enhanced, and we can find the lesion have already disappeared. So this case can be classified into CR or PR based on the RECIST criteria. And here I'd like to show another case. The lesions were planted with a hypoechogenicity over here and were planted with a hyper-enhancement in the early arch phase before the neoadjuvant chemotherapy, and the CT scan also can display the lesion size and shape. And after the chemotherapy, we can compare before chemotherapy and after chemotherapy, and the size and the shape have no change. So this one can be classified into SD based on the RECIST criteria. And another case, we can find the lesions before chemotherapy and after chemotherapy 2 months later, and the shape and the size have no change, and the enhancement pattern have no enhancement at all. So summary, double contrast enhanced ultrasound is promising as a non-radioactive, portable, and cheap methods to predict the clinical pathological features for gastric carcinoma based on its enhanced pattern, and its high accuracy in diagnosing the Bowman classification preoperatively, and also can be used to assess the effect of neoadjuvant therapy of advanced gastric cancers. Thank you very much for your attention.
Yeah, and thank you very much, Pintong. And yeah, that's interesting. It's interesting to combine an oral contrast agent with an IV contrast agent, especially in the gastric area. We did that years and years ago just with water, but maybe this has advantages over what we did in the past. Have you experienced with this? No. Anyone did this kind of filling, gastric filling with a contrast agent, or just with water? No. Okay, and we did that several times, but I must say, it is, number one, not that easy, and of course nobody who is older is capable of swelling water in an amount that is capable to image the whole gastric wall. So that was our limitation, but as a matter of fact, Pin Tong has a better outcome of his study.
Hello, I have just a little question. Why will we choose a double contrast enhanced ultrasound instead of endoscopy? Why? What kind of patients should undergo this first?
That's of course a good question, because each time that when you realize that there is an endoscopy indicated, you should do that.
You know, if you go to visit Pin Tong, it's absolutely astonishing just how different it is, and I'm sure it's more similar here to what it is where I live. So when you go there, they have hundreds of patients, and gastric cancer is a very, very much more common in Asians than in Caucasians. And so I think, you know, it's just one of those things that they have a very, very, very easy source of patients to study anything and to do anything. It's amazing. And, you know, they have it's almost like an ice cream dispenser. You know, you pull a ticket, the people that come to have ultrasound every day, and just hundreds go through it. It's really just a different world than where we are. And then, I don't know who's in the room right here, but certainly from the point of view of contrast ultrasound, I mean, China's the most rapidly growing utilizer of contrast and ultrasound in the world also. It's just different. I mean, you wouldn't think of doing it. And so if you were to say to your colleagues, your gastroenterology colleagues, that you're going to do an ultrasound to stage a gastric cancer, they wouldn't buy it easily either. So it's just really kind of an experience. But Pin Tong and his colleagues do very good work.
Yeah, I think it's completely correct. The situation in Asia is completely different. And I've been to several places in China, and the most interesting one was, I also visited Pin Tong, but I also was in Beijing, and the biggest hospital there has 2 million ambulant patients per year. 2 million per year. They have thousands a day. These are numbers that are unbelievable, and they have to get along with these patients. So it's just like when you go to a railway station and you see large queues of people queuing to buy a ticket. So this is the situation when you go to China and you look into the hospitals. So that is really a different story. And they're happy with every method that they can perform without getting big technical support for these examinations.